per the dictum dictates that it has to be a bleeding after menopause, any 12 months of no cycles in our age group that is bound to have menopause, and we should call it as a postmenopause bleeding. Then why do we have this definition of 6 months in between? Has anybody thought about it? The reason being that the diagnoses that are coming up with postmenopausal bleeding or the conditions that are leading to this particular case are having risky conditions as well. And that include malignancies as well, and we do not want to miss them out, and that is why a shorter period of 6 months hasn't even been taken up. So if I talk about defining it, I say that it is in the menopause that bleeding happens, I'll call it postmenopausal bleeding. Remaining, I'll call it as a perimenopausal age group or perimenopausal bleeding, and I'll club them together, even that 6 monthly bleeding that has been defined in short. So that is how we go for. 2014 onwards, all the various bodies have defined postmenopausal bleeding as any bleeding occurring in a postmenopausal individual. That means 12 months after the cycles are no longer coming up, that we define as clinical menopause. So with that background, let's move ahead with mean age. We talked about 45. I'll say that the age group is moving ahead in Indian population also. So 48.7 was taken up in the last census. If we talk about this one, it has moved further along. Now they are talking about 48 years of age, and we are seeing in clinical practice somewhere around about 48 to 50 years. That is coming up with Indian population. Western, they are coming further more. So 50, 51, they are probably going for menopause. Well, let's find out that how do we proceed on. Some things I'm going to skip in because I don't think we need to discuss it at this moment of time when you're ready for your examination. For PGs, it is a well-known knowledge. So causes, remember, either if you have to remember a cause, one more trick I want to, or tip I want to give it to you, that when you're defining causes or you're talking about a particular condition, learn to compartmentalize it. That means create a category for yourself under which heading you will be describing. So like we talk about lung or we talk about abdominal pain, we can talk about gynecological, obstetrical causes, and we can talk about surgical, medical causes and others. Similarly, here, if you are talking about postmenopausal bleeding, we can talk about local causes, that means vulva, vagina are taken together, then we can talk about, say, vaginal per se, cervical, uterine, and then we can talk about other genital organs, surrounding organs, and not yet classified or others. So what is the benefit of categorizing it this way? You tend to remember at least 2 in each category. To understand the number of causes you tend to remember at the end of your, say, learning period. So that is like compartmentalized. Same thing that I have done for you. There is a similar one that is available in the shores as well. If you talk about the local causes, you have many causes like vulva. If I talk about, there can be some ulcer, there can be some malignancy, there can be a polyp, there can be a benign lesion that might be bleeding. If I talk about surrounding causes, I can have uterine caruncle, I can have rectal mucosal prolapse, I can have fissure that she might be bleeding with. If I go on further, say enteritis and vagina, I can have vaginal ulcerations, growth again. Then I can have vaginitis, I can have atrophic vaginitis because with the age, the epithelium has thinned out and the bleeding has happened. If I talk about cervix, again ulcer, growth. Then if you talk about cervicitis or infective pathology, do not forget tuberculosis here. Now why I want to emphasize on this particular condition is that I truthfully have had a case in which, like the postmenopausal bleeding was a recurrent complaint that had been happening. This was a 53, 54-year-old lady. She had come to, she was obese, no weight loss. I think BMI was somewhere around about 25 or so for that lady. No history, anything per se beforehand, before she came to us. Last 3 to 4 months, she gave us 3 to 4 episodes of postmenopausal bleeding. There was a foul smelling discharge that was coming through the cervix. Once we did the biopsy, we always got an inconclusive diagnosis on the biopsy, but every scan was actually diagnosing a recurrent lesion. This is for you guys, huh? So once we, kept on repeating, initially we tried to treat her for infection, for other ways out, because we hadn't had a clear diagnosis of malignancy. We kept her under watch, but when the 3 episodes of postmenopausal bleeding happened, we took a call on that we are going to operate this lady. Now, after operation, the cervix and uterus was all replaced by fungating growth. That is what we could see after cutting her up. And there was no clear-cut demarcation between the different tissues, and we actually felt that probably we have removed a specimen of malignancy. Will you believe what came out on histopathology? Yes, it was tuberculosis. I definitely started not with that, but it came out to be tuberculosis, and we could not believe it that it was so. So do not forget tuberculosis in our country. And I appreciate Madam to pick it up in the last lecture, that to emphasize that tuberculosis is one part that should not be forgotten. Okay? So same way, the lesion can happen there. Then uterine, again, atrophic endometritis can happen, when malignancy can happen, a polyp can bleed, a leiomyoma. If you're talking about a leiomyoma, malignancy should not be forgotten. It should be kept in mind. Any leiomyoma that is suddenly increasing in size, presenting with post-menopausal bleeding, is having pain. Now this is a triad that screams leiomyosarcoma. Then we can have the two malignancies, ovarian. Do not forget that there can be, as Adam covered up in the morning, that ovarian tumors or cysts do not cause menstrual irregularities or symptoms. But there is one subset, and that is the hormone-secreting tumor. Granulosa cell tumors or malignancies that are involving the cells that are producing sex hormones can result up in menstrual irregularities and should be kept in mind. So with that account, you can have other category as well, in which say foreign body that can be there, or forgotten pessary or forgotten IUCD is a common cause. Wait guys, come on yaar. इतनी सारी गोपे मारने का टाइम लग रहा है. Hi, oh hello there. इसको ला दो भाई. Hi. Yeah. 1, 2, 3, 4, 5. Yes. Please stand up. Yeah. Don't look here and there. Please stand up. No, better. Diagonally to you. पीछे वाली रो. इसे पीछे वाली रो. Yes. सुन ले यार. पीछे देख के क्या करेगा? बैठो. Yeah. Finally, I could reach you here. Hi. Bladder, urethra as well. This is the typical nature of an atrophic ulcer, and understand the treatment here is to recognize and add up estrogen so that they are taken care of. But understand this estrogen that we are giving is a a double-edged sword. While we are giving it here, it might also cause some changes in the endometrium because it will not restrict just to the vaginal epithelium itself. And then you can have a bleeding because of the endometrial changes that are happening. So it's a double-edged sword. Be careful while we are giving it up, but that's the treatment that we have to take here. Myoma uteri we already talked about. We do not know which one of them are going to have a sarcoidosis change, but we understand that any neomyoma that is submucosal or has more of a submucosal component has more of a tendency to present with postmenopausal bleeding, so that can be thought upon. In any case of neomyoma uteri or fibroid should be kept under follow-up by a 6-monthly or a yearly checkup, and that is a good practice to follow. Adenomyosis. Now this one diagnosis I kept purposely here. Postmenopausal bleeding, adenomyosis, should it be here? Question. When we talk about AUP, we actually go on with the category that the treatment includes everything from thermal ablation to hysterectomy. That is why I kept this slide here. Do you think adenomyosis should be here? Hey guys, hello, hi. Should we have adenomyosis here? Should we? Should we have this slide here? Right?
How many of you believe that it is correct to have it here?
Should we have this slide here?
Raise your hands.
That's how many of you think that it should be here in postmenopausal bleeding? Nobody thinks? How many think that it should not be there?
They don't think either way.
They don't think.
This is very bad. Like there is a fundamental right to vote and you should vote. You cannot say on this government will support me, this will support me. Similar way, you cannot do this to me or any of your senior teachers who are sitting up here. You have to support one of the views, either yes or no.
How many for yes? It should be here. Please raise your hands. I have closed my eyes, I am not seeing your faces and I am not judging you.
See, this slide was kept here to understand whether you are awake or you are sleeping. I have justified keeping this slide also if you read the material written there. But understand that if you are talking about postmenopausal bleeding, anything that is related to reproductive age group automatically goes out of the list. So kindly do not put every diagnosis in. Neomyoma doesn't mean putting adenomyosis in the same basket. Do not put them in the same basket. Okay? This only will come up if there is an estrogen addition or hormone addition to it, and it might flare up. But understand, in a postmenopausal age group, adenomyotic lesions are supposed to regress and they go off. So there are no chances that adenomyosis is going to come up again. Okay guys? So remember, any diagnosis or any condition that is limited to reproductive age group will not be coming to postmenopausal or prepubertal conditions until unless there are specific conditions related to it. Will you remember this for me? That was a major crux of the lecture that I was actually doing. So endometrial hyperplasia, we have already talked about it, atypia and other changes. I am not going to go into detail. We have already covered that up from the morning part. The treatment we have covered up, endometrial carcinoma. I am not going to cover up that again because you guys know what are the risk factors for it. We have covered it up partially with the topics that we covered in the morning time, that you need to have obesity, hypertension and diabetes as one of the risk factors. Less of parity, more of the years when estrogen could act upon the ovary, infertility treatment. Then late menopausal NARCs, all those are included with that, family history. We all understand that. And so I'm not going to cover up this also. Folic carcinoma has been given up in literature. This is for my PGs, not for my UG. You are not going to remember folic carcinoma. PGs. This is a literature that I came across, and that is why I am putting it here for. This is for you, that this case has also been reported even in a postmenopausal way. Then next thing, upper genital tract carcinomas, which include fallopian tube. This is not for UG, for PGs, again. They also have a tendency to present in postmenopausal bleeding, And the postulation that has been kept is that whatever the bleeding is happening from the fallopian tube can either go to the peritoneal cavity or the extension can happen to the endometrium. And hence postmenopausal bleeding is one symptom that might be seen with fallopian tube malignancy as well. So the medications, post-hormonal or HRT, we understand. If you're giving hormones, the uterus is still there, the endometrium is still there. It will proliferate, it will work up. So that is why the miraculous 55 years old lady giving birth to a child. You remember? We had this news. So how does that happen? The hormones that are gone from the body are replaced and that is why they are giving birth. The same thing happens. If we are replacing the hormone, we are actually in a again, because now this lady will start menstruating. To understand that whether that bleeding is abnormal or not, the pattern is looked upon. If it is irregular, acyclical bleeding, then it has to be checked for any pathology that might be dangerous. The estrogen therapy, whether it is pervaginal or systemic, both of them can be associated with postmenopausal bleeding. Medications like anticoagulants, antiplatelets, shortcut preparations, dietary supplements, all those are associated. Even large doses of soy and phytoestrogens, like we go over for the patients to take care of hot flushes and all, can also be associated with postmenopausal bleeding. This is literature again that I have picked up from one of the sites in order to show you how the effects go by. This is for BGs. Diseases of adjacent organs, we have talked about it, I'm not going to talk about it again. Post-radiation therapy, we have talked about this as well. I'm going to skip this again. Infection, tuberculosis, madam has covered up for me, made my life easy, and we had a talk on that topic. So, genital tuberculosis should not be forgotten. Endometritis can be there. Now let's come back for the management aspect. 3-4 important points here again to take home with you. These are 3 points that we are going to talk about. We have to first distinguish a uterine from other genital tract bleeding because the management aspect is going to go. Once the first point is that the vaginal bleeding is attributed to intra-uterine source, it may arise from disease of any anatomic size in lower genital tract. So do not forget, diagnosis can be at any place of it, and you have to rule out or pinpoint what your diagnosis is. Your aim, first aim, should be to identify from where the bleeding is happening and why is it happening. So this is the first question to answer if you are talking about a postmenopausal bleeding. The second question to answer is that whether I am having a malignancy at hand or I am having a benign disease at hand. So if I am having a malignancy, my management absolutely goes different. With a benign one, my management is different. So that is the second point of interest that I have. The third point of interest is that if I am treating or taking care of this symptom, you understand why other things were taken or other lectures were taken with the diagnosis part. They were talked about with a particular condition and that condition was discussed. Here, a symptom is getting discussed. Now the symptom, why it is getting discussed is that the history and examination are the most important aspect of formulating a diagnosis in this case. So again, the 3 principles. The first one is to identify the organ and why the bleeding is happening. Second point, to identify whether it is benign or malignant. And third thing, examination and history are the most important part of reaching a diagnosis in this case. So with these 3 things in mind, let's move ahead. What are the various questions that we go for? So when was last period, when did bleeding start, precipitating factors, nature of bleeding, risk factors, were there any associated symptoms, then any associated symptoms, sorry, I repeated 6 and 7. Then personal history, family history, patient's medical history, HRT, coital relations, past obstetric history, surgical history, last year done, was it normal? All those questions you need to answer in order to reach your diagnosis, and I hope you understand where I am taking you along. The differential diagnosis can be established on the basis of the answer of this question. The clinical examination, general examination informs it. Then you have to think about the BMI of the patient because obesity is an important question. Then you have to talk about thyroid, pulse, blood pressure, weight loss, ataxia, fever. You have to understand how much of the blood loss that I am talking about. Is it so much that I need to do something about it? Then comes an abdominal and pelvic examination, and that is absolutely crucial. Having a look at the cervix tells you so many things, you know. If you have a look at cervix and this is how the cervix looks like, oh beautiful. So no growth, nothing, no ulceration. Then it tells you two more things. It tells you about the estrogenic status of the body, whether the cervix is, the body is having estrogen or not, because the cervix is long. If it is not a prolapse, you understand what vaginal elongation. A cervix that is not flushed with vagina, telling you that either the menopause happened recently or estrogen is still coming. A moist vagina. Moist vagina tells you that this patient is probably having estrogen still secreted in the body. A fleshy vulva, that gives you an indication that yes, the estrogen is there in the body. Now that information is also very important to you because it relates to your diagnosis. At times when what is happening, where the bleeding is coming from. And the tumor might be so small as 3 mm or 4 mm or a 3 cm tumor that might not be picked up on the examination or investigation that you are doing, but clinches that somewhere in the body the estrogen is getting released. Find out where the estrogen is and you might find the cause. So, aim of examination, determine the bleeding site, note any suspicious lesion, assess the size or tenderness of the uterus for regular examination, evaluation of the endometrium and cervix to be done, and ultrasound. As is there, ultrasound our best friend. So that is one important investigation that you need to think of. Crux you are given, any organ that is palpable abdominally has to be given both transvaginal and transabdominal. If it is there in the pelvis, a transvaginal sonography will be more effective. If you have to look up for lymph nodes or any abdominal organ, kindly pay attention. So in such a situation, you have to go for a transabdominal scan with transvaginal, even if the organ is not admitted abdominal. So that goes in. Aspiration cytology, yes, plays a role if you ask me. Pap smear do play a role, laparoscopy do play a role. And if you find anything abnormal, you have to work on. Now, postmenopausal bleeding, drugs, that if the bleeding is happening, endometrium, you find across the literature it has given as 4, 5, even less than 3. But the cases wherein the negative results came with 3 was very high. So 4 is a cutoff. 4 or more, you have to go for a biopsy. 5, if it is with some literature that is written on, do not confuse yourself. 4 to 5 लिखते हैं, but 4 हमारी cutoff है. यदि 4 है या 4 से ज़्यादा है, we are going to go for a biopsy. 4. Then if you are having a case with no bleeding at all, no symptoms, in that case 11 has been put in as a cutoff, that is international guidelines. But understand, polyp or structural abnormality or a focal enlargement has to be ruled out because at times that 11 is showing a polyp and we are not actually diagnosing it. So understand in such a situation, hysteroscopy is one good investigation to get done and a directed biopsy. So like this we have already talked about it too much. I think the natural and liquid pap, I'm not going to discuss it further. Almost we are not going to discuss it. Investigations, we have to go for endometrial sampling. We already talked about. I'm not going to talk about micro and all. Pepel, we already know of. Hysteroscopy, we touched it out. DNC, we touched it out. We had touched this as well. Proliferative endometrium, what we need to do, I'm not going to talk on. Ultrasound. Ultrasound not only mentions about the uterine sex, but this is one favorite question with the postmenopausal bleeding that we tend to ask. That if we are doing an ultrasound, what all will you look for? Now with that, you have to understand that uterine size, the endometrial thickness, any structural abnormality of the uterus, any myoma or any other lesion that you are seeing, that's one aspect. Do not forget the ovaries in such a situation. The volume of the ovaries is important because that might give you an understanding whether we are dealing with any ovarian malignancy or ovarian pathology as well. So do not forget that kindly. And definitely a firm body should be kept in mind every time you are talking about a postmenopausal. So ultrasound, let's skip. Investigations, MRI, cancer tumors, skip. Patients. Screen all patients with postmenopausal bleeding for endometrial cancer. Do not forget that because the incidence is rising and second thing it is a sinister condition, usually not visible like a carcinoma cervix. Use transvaginal ultrasound for the initial study of patients at low risk for endometrial cancer and an initial biopsy for those at high risk. That is how they say. So combining both of them gives you a better result. Use saline infusion sonography as a second step in evaluation of postmenopausal bleeding. The diagnosis remains unclear after a biopsy or the bleeding versus despite a normal initial workup. Hysteroscopy is the next option that you can think of instead of saline infusion sonography. Both carry the same sensitivity and specificity. As such, the method understands. This is the algorithm that has been done with. I am going to skip on. The crux is definitive management as per the underlying cause. So baki sab is automatically falling into place. Here I like to take in. If there is some initial evaluation, the pathology is not found. Have a look at the patient, find out why it happened, keep her under follow. If you find the pathology, treat that pathology. You do not need to be too much worried on, but do make them understand that they have to come up for follow-up if they need to get. Patients recurrently, this is one slide I need to go through. If it is recurrent or persistent, then in that case, hysteroscopy and further diagnosis for other diagnostic procedures are indicated. And persistent bleeding can be a sign of endometrial carcinoma even in a setting of a benign endometrial biopsy or thin endometrial spike on transvaginal ultrasonography. And this is something that I've experienced on my own. As I told you, that patients who are repeatedly bleeding, you might be missing them at some point or the other, and it's a good practice that since they are postmenopausal, that you take off the ovaries as well. So that is one thing. And question. 65-year-old patient complains of giant bleeding for 3 months, last menstrual period at age of 52, not taken any hormone replacement. She was diagnosed with type 2 diabetes, treated for borderline hypoglycemic, chronic hypertension, treated with oral antihypertensive, height 160, weight 90, physical examination, normal size uterus, no bulbar, vaginal or cervical lesions. Approach, diagnosis rather. Diagnosis, guys. So many things. I am proud of you for answering. Batao me.
No, it may be an endometrial carcinoma.
So think of endometrial carcinoma. Normal size uterus does not take away the diagnosis. Thank you so much. Does not take up the diagnosis of C endometrium. The remaining enlargement is there. It is not necessary to have an enlargement. You have to think of C endometrium with that. Thank you.
Well done. Very nice presentation. This is a very important topic for exam point of view and for clinical examination. You covered from top to bottom, A to Z in a well-done manner, and you covered all that is genital pregnancies also. Okay, very nice presentations. I hope students will benefit definitely. Thank you.